Okay, and we are ready to officially start. Would someone give me a shout out to tell me that you can hear me and see the shared screen? Anyone?
Yep.
Yes.
Yep, all good.
Yes.
Okay, great,
Looks good.
great. Then we're going to go ahead and start. You'll recall from last week when we were talking about quality control testing in the hot lab, the last thing that we took a look at was the aluminum ion breakthrough test, which you, of course, are very unlikely get a question about. And we're going to start today with in vivo non-imaging procedures. And as that name implies, in vivo, we are placing a drug in the body, but non-imaging, we're not taking a picture. We're going to be counting a body part or a body fluid, for example, but we're not forming an image of any kind. And there are not so many of these procedures remaining anymore because they've pretty much been abandoned for a variety of different reasons. We'll talk about a couple of those. So the first thing I wanted to talk about briefly is the red blood cell survival procedure. This is one of several studies that are performed using chromium-51 labeled autologous red blood cells. Autologous means that the cells came from the same patient. They're not donor cells. And the typical dose is 50 to 100 microcuries, but probably an average of about 70 microcuries per study. And this procedure is used probably 99% of the time to evaluate a patient with some kind of anemia. We already have a diagnosis of anemia. We are not trying to make that diagnosis. We're trying to guide the referring physician as to how to treat the patient by determining how long that person's red cells are surviving in the circulatory system. And so you'll see that a normal value is approximately 30 days. Most books say 28 to 35, but most of the procedures I've seen, the half time of survival is about 28 to 30 days. That's very typical. And while it says survival time, we are really measuring the half time of survival. It's like a half-life, like a biological half-life, basically. It's very simple to label red cells with chromium. We take about 20 or 25 milliliters of whole blood. We anticoagulate it with either citrated dextrose or heparin, and we simply add chromium-51 chromate to it, incubate 15 minutes, and we're done. And then we do blood sampling at time 0 and on a daily basis out through as many days as we need to know the exact slope of the curve. And once we know the slope of the curve, we're done. That often takes 6-7 days. Occasionally we have to go out to day 10, but that's pretty uncommon. And the data analysis is performed on actually semi-logarithmic paper. I'll show you a graph in just a moment. And what we are taking a look at is the change in the count rate as a function of time. So here are two curves. You can see that this is a higher up curve right here and a lower one down here. And remember, we're doing a half time of survival. So we simply find the percent line, 50% line. You'll note, by the way, that because this scale is logarithmic, it doesn't go 150 in the middle and 0 down here. It's going from 100 to 50 to 25 to 12.5 and so on. So this is a log scale. Time is, of course, linear. And so which of those two curves represents a normal half time of survival, the top curve or the bottom?
The bottom.
So the bottom curve at the 50% level, if we go over to the curve and drop down a vertical, that's only going to be 10 days. So that would certainly not be normal. In fact, that'd be quite abnormal. On the other hand, this top curve, the 50% line intersects the top curve right here. If we drop the vertical down, it's approximately 28. That is a totally normal value. So the top curve would be the one that represents a normal study. Now, this is a very interesting question, and it has a simple answer, but it's not so intuitive, really. If the expected lifetime of a red cell is 120 days. Now, I've never been to medical school, but every physician who has will tell you that red cells live for about 120 days and they die. So that's the expected lifetime, not the half-time, but the lifetime. They live for 120 days and then they die. So one would normally think that then why the half-time of survival should be half of that number, or 60 days, but it's not. Why is that half-time of survival only 30 days and not 60? And the reason is the following. When we take that blood sample out of someone's arm, how old are those cells? Anyone? So those cells are every age imaginable. Some of them formed 1 minute ago, and some of them are 119.9 days old and are ready to die. So they're every single age. So if you take that population of cells and take the average lifetime going from day 0 to day 120, the average half-time of survival, the average lifetime for that population of cells is probably 60 days, and therefore the half-time of survival would only be 30 days. This is called random labeling because the cells are randomly aged. They're every age from day 0, the day of formation, up to 120. And so we are radio labeling indiscriminately all the cells, regardless of their age. This is also true, by the way, of any other isotope that we hook to red cells. That's also true. We would expect the half-time of survival to be the 30 days. Where that does not apply is something called cohort labeling. And the only example we have of that is that we can label red cells with iron. We typically don't do that because the iron isotopes are really not available anymore. But when is iron incorporated into a cell? On day 0. Only newly formed cells are incorporating iron. Iron does not label to cells that are already in existence. And so what happens here is that all the cells are labeled on day 0. They all live for 120 days, and they all die at the same time. So there really is no half-time of survival at all with iron or with any cohort labeling. That's only true for random. Limitations of the study are several. Number one, if you damage the red cells, you're going to get an artificially shortened survival time. And here's how damaging the red cells takes place. It has mostly to do with people's brains. If they're making a bad decision and getting a very small interior diameter needle, like a 25 or a 23 gauge needle, you are asking for trouble. The patients don't like 19 or 18 gauge needles because the bore of that diameter is pretty large, and it's kind of frightening to have that big needle pushed into your arm. But we have to use a large needle like an 18 gauge, and we have to draw that plunger back very slowly and inject that dose very slowly. Otherwise, we will damage some of the cells and we will get an incorrect survival time. Also, this is a very time-consuming procedure, not so much for us, but for the patient. The patient has to come to the lab on day 0, and then come back on day 1 and day 2 and day 3 and day 4 and day 5 and day 6 and day 7. And for anyone who has a job, that's very time-consuming. We've had people say, I just can't take any more time off work. You're going to have to make a decision based on the data you've already got. So that is occasionally a problem. Also, you can imagine that if the patient happens to be bleeding at the time of study, there is no way to get a correct survival time. And sometimes this rarely happens, and we sometimes may not even know the patient is bleeding at the moment because it might not be a significant kind of bleed. The other studies that we can do with chromium would be a plasma volume study coupled with what we call a chromium red cell mass study. And we're trying to rule out a disease called P. vera, polycythemia vera. It's a condition where the bone marrow produces way too many red cells. The patient's hematocrit goes up, the blood becomes very thick and viscous, and imagine your heart having to pump something similar to motor oil rather than blood. What happens to these patients if they go untreated is almost all of them would die within a year just from heart failure. And so there are fortunately some good treatments today. And this test is used to evaluate a patient to see if there is polycythemia vera. And so we use two different isotopes. We have I-125 human serum albumin. This has a 60-day half-life. We only have to give 10 microcuries. That's to measure the plasma volume because serum albumin stays in the plasma space and does not bind to red cells. And on the other hand, we have the chromium red cells to look for how much red cell mass there is. And so I'm not going to go through these procedures. I'm going to skip a couple of slides here. I do want to mention this. This is a common exam question. They call this the principle of isotope dilution. What we are doing is diluting the isotope in the whole blood, sampling a small volume, a known volume of that blood pool, and back calculating what the total plasma volume is or what the total red cell volume is. And that's called the principle of isotope dilution. And so here's how we interpret the study, and I'll show you a couple of interesting studies. The volume that we measure should be within 15 to 20% of the volume that we look up in a table. We get the patient's height and weight, we look it up in the table. We can say that someone my size, for example, should have about 3,300 milliliters of plasma and 2,200 milliliters of packed red cells. That's normal for someone approximately my size. So here are a couple of examples. In the first column, you'll see the expected value. These numbers came from the chart based on height and weight. So this is what is normal. Here are the measured values. This is 3250, only 1.5% low. This number is only 2% high. And by coincidence, the total blood volume is totally normal, zero deviation. So what would our diagnosis be here? So these numbers here, minus 1.5 and plus 2.3, are so low that this is a totally normal study, well within 15 or 20%. How about this study though? The plasma volume is minus 23%, very low, but the red cell volume or the red cell mass is totally normal. So what's wrong with this patient? Now he's going to have an elevated hematocrit, and the doctor might initially think, oh, this guy has polycythemia. But what's wrong with this patient is simply severe dehydration. His plasma volume is 23% low, but he's got the totally correct number of red cells there. And so he's just simply severely dehydrated. I've seen a patient like this before, where the plasma volume is totally normal and the red cell volume is elevated by 20.5%. That is simply polycythemia vera. That is a classical case where the plasma volume is totally normal and the red cell mass is elevated above 15 or 20%. And finally, I've seen this patient 2 or 3 times in the last 35 or 40 years, where the plasma volume was roughly minus 20%. The red cell volume is plus 20%. This is abnormal. This is abnormal. This, by coincidence, is okay. And so what we have here is a severely dehydrated polycythemic patient. This guy is in bad physical shape. His blood is going to be like coal tar. I mean, he's got way too many cells, way too low an amount of plasma circulating. And so if we don't fix him quickly by, number one, rehydrating him, and number two, getting those red cells down, then his survival time is not going to be so very long. Okay. The most important of all of the in vivo but non-imaging procedures is the RAIU. And I think in the very first lecture, I mentioned to you that that acronym appears on the board all the time. Who knows what that stands for? RAIU. So the answer, of course, is right in front of you. Radioactive iodine uptake test. So if someone says we're going to perform an RAIU, what isotope would we use? The answer is going to be I-123, typically. The only time we might use I-131 is in the case of a patient who has a substernal thyroid, and that only occurs about not even 1% of the time. It's really pretty rare. So don't expect to see the whole sentence of radioactive iodine uptake tests on an exam. You'll probably see RAIU. Now, here's the question we want to answer on an RAIU. We have radioactive iodine in a capsule or maybe multiple capsules. What we want to know is what percent of the iodine in the capsule ends up in the patient's thyroid gland at 24 hours post-administration of the dose. That's all we want to know. What is that percent uptake at 24 hours? A number of years ago, many physicians used to compute a 6-hour uptake and a 24-hour. Turned out the 6-hour uptake was a very unreliable way to do it, and that was abandoned fairly quickly because the 6-hour uptake varied tremendously from patient to patient. So it's only at 24 hours. Now, the first thing we do before we do anything that you see on this slide is that we have a physician to interview the patient. There are so many things that interfere with an RAIU that we have to make sure that those interferences are not present. For example, if the patient, this might surprise you, but if the patient has been eating sushi every night for the last 2 weeks, you don't want to do an RAIU on that patient. He has swallowed so much seaweed, which contains so much iodine, that it's going to depress thyroid function and the number is going to be artificially low. What if he's had a CT scan with contrast media containing iodine? That's an interference. What if he's on Synthroid or P2U or some other thyroid blocker? That's an interference. There are many, many medications that interfere. So we have to very carefully interview the patient and make sure that he qualifies for the study. Now, once we have done that, we have a qualified patient, then we make sure the patient is NPO for midnight, nothing from midnight. We usually schedule a morning appointment. Patient comes in, we give 1 or 2 or the required number of capsules with a cup of water. And then the patient has to remain NPO for 1 more hour after swallowing that capsule. Shouldn't be even drinking water, no smoking of cigarettes, nothing at all like that. And then we bring the patient back for 24 hours and we will going to count the patient. And also we're going to count a capsule in a similar geometry to how we count the patient. And here's the computation that we're going to do. Net counts in the thyroid at 24 hours divided by net counts in the capsule either at 24 hours. In other words, if we count the thyroid and the capsule at 24 hours, and an extra capsule, we don't have to decay correct. But let's say you buy 1 capsule, you calibrate it at times 0, and the patient swallows it. You don't have another one for standard. You then have to decay correct the counts in that capsule forward 24 hours to correlate those counts with the patient's thyroid count at 24 hours. So we only have to decay correct if we don't count a standard capsule at 24 hours. So we take these counts in the thyroid, net counts, divided by net counts in the capsule times 100%, and that will give us the percent RAIU. Now, here's a problem that we're going to kind of work together. And the next slide is going to be a blank slide so that in your course notebooks, if you want to give that problem a try, you'll have a space to do so. So let's take a look. The patient swallowed a capsule at time 0. Patient then returned at 24 hours for counting. Half-life of iodine is 13.3 hours. So remember, we counted the capsule at time 0, but we're counting the patient at time 24. So the decay correction factor for 24 hours for I-123 is simply 0.2863. Now, would that be easy to calculate? Very easy. Remember that the fraction remaining is 1/2 to the n, 0.5 to the n. N is the number of half-lives. On our calculator, we would take 0.5 to the power of, in parentheses, 24, that's TLAPS, divided by 13.3, close the parentheses. That will give you 0.2863. Now, watch the numbers here very carefully, because we often count background for much longer than we count the patient. Patient's counts are going to be high, background counts are going to be very low. So let's say we got 1,000 counts background in 5 minutes. That's going to be 200 counts per minute. Let's say the capsule background was exactly the same, 200 counts per minute. The thyroid count will be at T24 will be 25,000 counts per minute, and this will be 150,000 counts per minute. In other words, you want everything in terms of counts per minute. And then we're going to do the decay correction. Here's your blank space if you want to try the problem in your notebook. And so here's what we're going to do. The net counts will be the 25,000 counts per minute thyroid minus 200 counts per minute body background. We usually count the patient's 5 for that reading. The decay correction would be like this. We have 150,000 counts per minute in the capsule minus 200 counts per minute background. And then we do that subtraction and multiply by 0.2863. This came out to be 58.7%. Is that a hyperthyroid patient, a normal patient, or a hypothyroid patient? Who knows?
Hyper.
Hyper.
Definitely hyperthyroid. And how do you know? Because here's the rules. A normal patient typically is around 8 to 30%. Now, a lot of physicians have other numbers they use. I know 2 hospitals in Chicago that use 7 to 33. We use 8 to 30. Some use 8 to 35. So 7 or 8 on the low end is normal, and 30 to 35 on the high end is normal. And anything outside of that range would be either hypo if it's lower than 7 or 8, and hyper if it's above 30 or 35, depending on whatever limits your hospital has chosen to go with. Now, here are some of the interferences. I mentioned a couple of these, but we'll focus on them a little bit more. Any contrast media containing iodine. That does not include MRI contrast. That does not contain iodine. That's not a problem. But anytime anyone has like an IVP or a CT scan with contrast, that is a big interference for as short as a month and sometimes a lot longer. There are certain vitamin preparations that actually contain potassium iodide, and there are cough drops also that contain iodide. And so those can be interferences. I mentioned earlier, Synthroid, propylthiouracil, there's a drug called Tapazole, something called thyroid extract that is extracted from animal thyroids, and all of those are interferences, as well as anything that that came from the ocean, which is, picks up iodine, like kelp and other kinds of seaweed. Anytime you're eating sushi, you're eating seaweed, and that is increasing your dietary iodide uptake, and it's going to decrease your RAIU. Now, here are a couple of interesting board questions. Why has the upper limit of normal decreased in the last, I think 20 years is now a bad number, probably 30 or 40 years. It used to be, let me back up a little. It used to be that the upper limit was 35 to 40. It's now dropped to 30 to 35. So why has that upper limit dropped in the last several decades? What are we consuming these days that we did not consume 30, 40 years ago? Anyone? How about iodized salt? You cannot get away from it. Manufacturers use it in almost every product on the market. And most of the salt shakers that we use at home contain iodized salt. And so because of that interference, the upper limit of normal has dropped over the last several decades. This is a common exam question. If a patient is taking Synthroid, Synthroid is a mixture of T3 and T4. how long does the patient have to be off of that drug to register a valid RAIU? 3 days, 1 week, 2 weeks, or 4 weeks? How long does Synthroid interfere?
4 weeks.
What?
4 weeks.
Perfect. The answer is either 4 weeks or a month. Either one is totally acceptable. These other drugs like PGU and the other ones I mentioned, those are more like 7 to 10 days. But Synthroid is the biggest problem. And I cannot begin to tell you how many millions of people in the general public take Synthroid. Many, probably the majority of them are women, because they're more prone to thyroid disease in the first place, especially hyperthyroidism. What about Inderal? Now, many patients who are hyperthyroid have elevated pulse rates. You know, your pulse rate and mine might be 60, 70, maybe even 80, but hyperthyroid patients have pulse rates that are often 90, 100, 110. That's just a resting pulse rate. So they're put on a beta blocker, and the one most commonly used is called Inderal, which has another name of propranolol. And so here's your question. If someone is on Inderal, is that a problem with an RAIU? And the answer is, fortunately, it is not. There are beta blockers that interfere, but Inderal is not one of them. Okay, there are procedures I did not talk about, like the Schilling test. I took it out of the notes because it's been unavailable for 15 years and no one should be asking you about a Schilling test at all. So let's take a quick test. There are going to be a few questions in here that we may have to skip off to see what's in here. Okay, which one of the following is not an example of an in vivo but non-imaging procedure? Anyone? So the correct answer here is a radioimmunoassay, where we don't do anything whatsoever to the patient other than taking a blood sample. We don't do anything. In all these other procedures, we administer a radiopharmaceutical, we perform a test. That is not the case with an RIA. So that would be choice A. The typical injected dose of chromium is how many millicuries? Now, earlier I quoted that number to you in microcuries. It's in microcuries. This question is asking millicuries. Anybody know which one it is?
C.
0.75.
It would be choice B, 0.075 millicuries multiplied by 1,000. That would be 75 microcuries. Okay. The normal value for the half-time of survival of chromium red cells is approximately?
Say A.
Good. 28 to 30 days. Perfect. Sorry. Okay. Why do we perform a plasma volume and red cell mass study together? And that is B, to diagnosis polycythemia vera. It's separated out from severe dehydration and other things. Okay, plasma volume study is based on the principle of what? Choice B, isotope dilution. Again, common exam question. This one I don't think I showed you this one before exactly, but what do you think here? Well, maybe we did. We have a plasma volume study where it's elevated 3%. The red cell volume is elevated over 20%. What's your diagnosis here?
C.
C, that would be polycythemia vera, where you have an elevated red cell mass, but plasma is totally normal. Typical administered dose of sodium iodide I-123 for performing an RAIU is how many millicuries?
A.
A.
Good. A, we typically give 200 microcuries or 0.2 of a millicurie. I'm asking you this question because when you become a practicing technologist, you're going to discover that the computer will only accept a dose in millicuries. does not recognize microcuries. If you put 200 in there, it would think it was 200 millicuries. So 0.2 of a millicurie is 200 microcuries. Very good. Okay. Typical administered dose of I-131 sodium iodide for performing an uptake and scan in a patient who has a substernal thyroid. I don't think I actually mentioned that, but the answer is 100 microcuries of I-131, which is choice A, 0.1 of a millicurie. Okay. Which of the following is not a required part of the preparation for an RAIU? Let's go down the list. We have to discontinue Synthroid for 4 weeks prior to performing that test. That is a required part. Patient has to be NPO from midnight until 1 hour post admin of the dose. That's required. Patient must discontinue propranolol. That's Inderal for 4 weeks. That is not required. Patient must not have undergone a CT scan, contrast media containing iodine. That is required. So choice C is the only thing we do not have to do. See, here we go. So we already had covered this. If the RAIU is 58%, we know that that is hyperthyroidism. And here are the numbers that we looked at a few moments ago. Okay, that's a fairly comprehensive overview of the tests that are performed today. And again, the RAIU is the most commonly performed one, more so than all the rest of them combined. And every department in the United States is able to perform a thyroid uptake test. Any questions about any of those procedures? Okay, good. Now, we're going to cover one of my favorite topics, which is radionuclide therapy. And I often think about the silver bullet concept, where if you can find the silver bullet, the magic bullet, you can cure a disease by targeting that disease with a particular radiopharmaceutical. We're going to see some wonderful examples of that. We can't cure everything. We can't even cure all kinds of thyroid cancer, but we can certainly cure the majority of them. So let's take a look. What kinds of therapies are performed in hospitals today that use radionuclides for therapy? So number one, what we're going to focus on for the next hour will be radiopharmaceuticals, but there also are isotopes in what are called brachytherapy sources. These are sources that are implanted in patients. For example, men who have prostate cancer that may be untreatable by other means, they insert 100 or so I-125 seeds hermetically sealed within a metal capsule. They're very, very tiny. They're less than 1 millimeter in diameter, maybe 3-4 millimeters in length. They're very small. And there are other kinds of brachytherapy sources. We'll look at a list of them later. And finally, in the conventional radiation therapy department, they perform what's called teletherapy, therapy at a distance. So the only one of these where something is placed in the body as an unsealed source is radiopharmaceuticals. Brachytherapy is a totally sealed source. They either are placed in the body and left there forever, or maybe placed locally, held there for X hours, and then removed. And teletherapy, again, conventional radiation therapy. Now, we defined several weeks ago what a therapeutic radiopharmaceutical is. So instead of boring you with all of those details, we're going to flash through it pretty quickly. We define that therapeutic drug as a radioactive drug that we use for the purpose of performing a radionuclide therapy. And what we anticipate is that there's no physiological response at all on the part of the patient. The patient cannot tell whether he swallowed sodium iodide solution or water. Today, we don't even use the solution anymore. We only use capsules, but we don't expect any kind of physiological response. In fact, the only thing I've ever read about is for performing hyperthyroid therapy, Sometimes, sometimes patients end up with a hoarse voice, but even that's pretty uncommon. Here are the properties of the ideal therapeutic. And again, we covered these in the pharmacy lecture, so we'll flash through them quickly. Number one, we want a moderately long T effective. That means something that's measured in days. We want to confer that dose over a number of days, not over a number of hours. And a perfect example is for treating hyperthyroidism with I-131, the T effective is 6 days. Couldn't be better. Patient would think, I want to be cured today, but they're not going to be. It's going to take 6 weeks, 6 to 12 weeks for them, let's say 6 weeks to begin to feel better, and 12 weeks is about as good as it's going to get. Secondly, we want, number two has two things in it. We want either alphas or betas. We want them to be high energy. The higher the energy, the better. Now, you'll recall for diagnosis, we said we wanted an energy between 100 and 250 keV, because that's where our gamma camera worked the best. Here, we don't have a gamma camera we're even using. Patient's going to swallow capsule. We're going to say, goodbye, go home, good luck. And there are no images being taken at all. So we prefer the very high energy alphas or betas. We must have a very high target to non-target ratio that thereby confers minimal radiation dose to nearby organs close to the target organ. And also, for any unbound material, unbound to any body part, we want it rapidly excreted. And lucky for us and the patient, iodide is not taken up, is excreted very, very rapidly in the urine. And that's why when we treat a cancer patient in the hospital, their T effective is only about 1 day. And they're usually only hospitalized a couple of days. Number one, they have no thyroid. We can't treat thyroid cancer until the thyroid has been surgically removed. So that is a key point. You just have to get rid of that thyroid. Minimal radiation exposure to people in contact with the patient. The way we can achieve that is to use an isotope like P32 or strontium-89 or yttrium-90, where the dose administrator is going to pick up almost zero, because those are not gamma-emitting nuclides. In fact, I-131 is the worst nuclide we ever have to deal with from the standpoint of the dose administrator. We simply cannot shield ourselves from the photons. What we need here would be several things. Number one, an internal organ or system in the body that we want to treat. And we must have a normal metabolic pathway that can have that radionuclide taken up and localized in that internal organ. So that's the first thing. We need a metabolic pathway that works. Number two, we need a radionuclide or an analog that will be concentrated and can deliver the appropriate dose. I'll give you an example. The radionuclide of choice for palliating pain would be calcium. Calcium goes right to bone tissue. It's incorporated. It's got a long biological half-life. The problem is we don't have a good calcium isotope to use for therapy. So instead, we use an analog. For example, strontium is an analog of calcium. It's right beneath calcium in the periodic table. And radium, like Xofigo. Radium is also a calcium analog. So both of those concentrate in bone tissue just like calcium does. Thirdly, the nuclide must not confer an excessively high radiation dose. We're not talking about the target organ, but the rest of the body. Some of the basic principles. Also, we need to know the internal dosimetry. That will never, ever be a problem, because by law, the package insert must contain the internal radiation dose. It must tell you the dose to the target organ, the whole body, the liver, the kidneys, the blood pool, and a number of other targets. So we have to know the dosimetry. We need a drug that's readily available. We will never have, bullet to point number three, a reasonable cost. All of the most recently approved drugs cost anywhere from $15,000 up to almost $100,000 to treat a patient. So they are extremely expensive. And unfortunately, in some cases, the insurance companies balk at paying for them, and the patient ends up responsible for them. And the average guy on the street can't afford $100,000 therapy. So that can be a real problem. We prefer beta particles historically, but now also we will take alpha particles. In fact, alpha particle emitters, as you're going to see in a little while, the dose that we administer is literally microcuries per kilogram, not millicuries, but microcuries, because they have the potential to confer such a very high radiation dose to the patient. Also, as I mentioned earlier, half-life has to be moderately long, measured in days. Now, if you take a look at all the types of emissions used for radionuclide therapy since approximately 1900, they all fit on one slide. We have alpha particle emitters, beta particle emitters, we have electron beams, we of course have gamma rays, X-rays. If you listen to the radio when you're driving in your car, you might hear about a proton beam therapy center. We have one near Chicago, and I hear their ad all the time on the radio, proton beams, and they have done some miraculous saves of patients who have totally inoperable tumors. The proton beams can be focused so well that they can destroy enough of the tumor that a surgeon can now go in and operate and remove the remainder. But I think the important thing here is that all of these, only half a dozen of them, they all fit on one slide. It's interesting, by the way, you all probably remember who Alexander Graham Bell is, the inventor of the telephone. Back in 1902, he proposed injecting radium directly into malignant tumors to try to kill them. And in fact, that has been done in the past with some success. Many years ago, it's not typically done anymore, except for implantation of brachytherapy sources. But there's a very, very long history of using radionuclides for performing therapy. Also, if you take a look, all the nuclides that we use today and have used historically also fit on one slide. We have iodine 131 in the chemical form of sodium iodide for treating thyroid diseases, both thyroid cancer and hyperthyroidism. We have P32 for treating polycythemia vera, not commonly used anymore because there are non-radioactive ways of treating P. vera. Certain chemotherapy agents that work, they're called alkylating agents. We have 4 isotopes, P32, dating back to 1945. Strontium, proved in 1996, I believe. Strontium was 1988, samarium was 1996. And then we have, about 3 years ago, radium-223 Xofigo for palliating a pain. We have, for treatment of non-Hodgkin's lymphoma, we have yttrium-90 in the chemical form Zevalin. It's an anti-lymphoma antibody that targets what are called the CD20 receptors on B-cell lymphoma. And we're going to talk a little bit more at length about that in a little while. We have yttrium-90 in the form of microspheres. There are glass microspheres and polystyrene resin microspheres, and both of those are utilized to palliate the pain, to treat liver metastases, mostly in patients who have colon cancer. And one of the criteria is that if there are liver metastases and there are no metastases anywhere else in the body, you can accept that patient. If there's metastatic disease in places other than the liver, the patient will not qualify to be treated. So these little microspheres are injected through an artery through a catheter, where the tip of the catheter is placed in the hepatic artery and infused right into the lobes of the liver. Also, we have lutetium-177 for treatment of certain kinds of neuroendocrine tumors. We have a couple more slides on that a little bit later. Now, one way that the NRC used to look at therapeutics, but not anymore, at least not in the regulations, is they had 6 categories of drugs. First 3 were therapeutic, and the last three had to do with diagnosis. And so here was their way of thinking about therapeutics. Number one, we can give therapeutics where we do not ever have to hospitalize the patient. Number two, there are therapeutics where we do have to hospitalize the patient. And number three would be brachytherapy sources. So here are some where we never have to hospitalize a patient. Treating a patient for hyperthyroidism, assuming there are no other medical issues involved at all, we give iodine, we send the patient home, wish them good luck. B32 for polycythemia, we never had to hospitalize. Strontium chloride, we never had to hospitalize. These are both pure beta emitters. They pose no risk to family members of the patient and no risk to the dose administrator. And so that didn't require hospitalization. Also, yttrium-90-zevalin, the anti-lymphoma antibody for treating non-Hodgkin's lymphoma, we never had to hospitalize for that. Here are some where we might have to hospitalize the patient, but it is very patient dependent. Back in 2006, when the NRC updated their regulations, they included the option of making a medical decision about, is this patient going to be able to stay safe at home and remain compliant with all the radiation safety rules and regulations. Before 2006, you had to hospitalize every high-dose iodine patient with thyroid cancer. Today, we send everybody home except, let's say the patient is demented, can't follow the rules. Maybe it's a 95-year-old patient, can't follow the rules. Maybe it's a child. Anyone who is unable to be compliant with the radiation safety rules and regulations, we have to hospitalize them. Personally, I never understood this because instead of the patient's family getting dosed, they're dosing the same few nurses in the same hospital who have been trained to deal with radioactive patients. So somebody's going to get dosed, and it seemed to me it's kind of a toss-up. Is it the nurse or the family? But in certain cases, there is no choice. Finally, I mentioned earlier these sealed sources, which may be implanted in patients, and they're not all implanted. Here are some other examples. A bone mineral analyzer today we're using X-ray sources, but in the early days of bone mineral analysis, we use both I-125, I don't see it here. Yeah, here it is. I-125 as a sealed source for bone mineral analyzer, and you can use americium-241. We have a lot of isotopes here, cesium and cobalt and gold, iodine, iridium, strontium, more iodine, and they're in a lot of different physical forms. There are sealed sources, there are needles, there are seeds, there are nylon ribbons containing seeds and eye applicators. There are lots and lots of different kinds of therapeutic sources that are considered brachytherapy. I don't think you need to know the isotopes particularly, but you should know that brachytherapy sources are hermetically sealed sources containing radioactivity. The radiation therapy department is totally accountable for all sealed sources. If you have lost a source and not reported it, that is going to be a citation. That's going to be a citation. The best thing you can do if you lose the source is simply to report it. Then you will not be cited. Every source, every sealed source must be leak tested every 6 months. That's federal law. And if a source is leaking, it must be simply taken out of service. Now, let's take a look at the treatment of thyroid diseases in particular. Hyperthyroidism, often referred to as Graves' disease. We have toxic nodular goiters. You know them as hot nodules. Sometimes they're referred to as autonomous hyperfunctioning nodules. And if there's more than one, that is multinodular goiter. It's often called plumber's disease. I'm going to ask you a question shortly about which one of these requires more activity to cure. Thirdly, there are 4 kinds of thyroid cancer. Follicular and papillary cell carcinoma pick up iodine very avidly, and that makes them very treatable. The other 2 types, medullary and anaplastic thyroid cancer, are not treatable. Now, there's also what's called mixed tumor types. That is, let's say if a patient had medullary and follicular together, it might be worth a shot because the follicular might pick up enough iodine to treat both of the different different tumor types. So you should know that follicular and papillary are treatable, and anaplastic and medullary are not. Now, when we treat iodine 131, when we treat with iodine 131 for hyperthyroidism, here's what the results are. If you know the best way to determine the dose, and we'll talk about that, you can cure 85% of all people on the first dose. That's a pretty good cure rate. And then if you don't cure them on that first dose, the second dose picks up almost all of the rest. Very rare to need more than 2 doses. Also, for thyroid carcinoma, those 2 curable types, those 2 there, follicular and papillary, there are now survivors. I would say 20 years is a bad number. I need to update it. Probably 40 years is more likely. In fact, this disease is so curable that the people, when they die of something totally different and not thyroid cancer at all. So once it's cured, and the cure rate is quite high. I don't know the numbers, but quite high. How do we determine how many millicuries to give? So typically, patient has thyroid cancer. The cancer has been resected surgically. Now there's no thyroid there. And we will then do a whole body thyroid scan to see what's remaining. We're looking for 2 things: remnants in the neck and remnants at thyroid cancer metastases. It could be anywhere in the body. So if we're suspecting only, if we only see on the uptake study a neck tumor but nothing else, then we would start with probably 150 millicuries. If there are also bony metastases, then we would give 200 millicuries plus some external beam therapy that's like just conventional radiation therapy. And on the bottom, for lung metastases, this is the worst possible case that you could have. And here's why. The lungs can tolerate up to about 3,000 rads of radiation. And then they become so fibrous that the patient really can't breathe very well. And so while you can cure that cancer, you can kill the patient with that overdose of radiation to the lungs. It's like walking a tightrope. There's a very fine line between failure and success. Very fine lines, very hard to hit that. Our Dr. Wagner in our department at Loyola treated a young lady. She was 9 years old who had thyroid cancer metastatic to her lungs. That is extremely unusual in anybody, and especially a 9-year-old. So he started out with a pretty high dose, like 150 millicuries. He brought her back at, I don't know what point in time, did a whole body scan, and gave her another dose. And we're happy to report that she is now in college, close to graduation, and doing extremely well. So he just hit the nail right on the head with the correct dose for that young patient. It's very hard to calculate therapy dose for a child that young, 9 years old. These numbers were presented in the big chart that we looked at a couple of weeks ago. So I'm only going to show you the bottom 4. A total body metastatic survey, that's a fancy way of referring to a whole body iodine scan. We typically would give 5 or 10 millicuries of I-131. We have now switched over to I-123, and we give about 10 millicuries of I-123. All these are oral. For a hyperthyroid patient, normal first dose is about 8 to 10. Second dose, if the first dose fails, the second dose has to be 50% larger. So if the first dose would be 8 to 10, and there's a failure, then 50% larger would be 12 to 15, and that's where the 15 came from. This includes first and second doses. For that hot nodule, 25 to 30 millicuries is very typical. And for thyroid cancer, many years ago, people used to use 75 millicuries and try to titrate the dose of the patient. That is a very bad idea. It actually increases radiation dose to other parts of the body. You're better off to give a 150 millicurie blast all at one time and cure the patient in one dose. It's better not just financially, but better for the patient. So you'll see here that the second dose, if you started with 150, the second dose you had to give it would be 225. Again, that's a 50% increase. Now, here are some fascinating numbers as far as I'm concerned. For Graves' disease, when we give 8 to 10 millicuries, a 10 millicurie dose confers, if someone has an uptake of, let's say, 50%, 10 millicurie dose confers a 10,000 rem dose to the thyroid. Now, if you recall from the last time when I talked to you about the LD100, the lethal dose where everybody died, we said that was 550 rems. But remember, that was a whole body dose. The whole body dose in the case of Graves' disease is very small, probably 10 or 15 rems, pretty small. This is a single organ dose of 10,000 rems. Plummer's disease, that hot nodule, we're giving 25,000 rems. And look at this number. Thyroid cancer, here's why that cure is so effective. When you're giving 100, 150 millicuries, you are conferring a dose of more than 100,000 rems to the tumors, while a relatively minimal dose to other parts of the body. That's why it's such an effective therapy. Now, you look in the package insert. I took this from the Mallinckrodt's package insert for I-131 sodium iodide. And look what it says. If you have a patient with a 50% uptake and you give that patient 10 millicuries of I-131 sodium iodide to treat hyperthyroidism, then number one, 90% of the dose was caused by the betas. Even though there may be more gammas than betas, remember, betas have a high LET. They confer a very high percentage of their energy into the body, but for gammas, very small percent. Gammas escape the body. They typically deposit 10 or 20 or 30 or 40% at the most. Betas deposit almost all of it. So they do 90% of the tissue damage. So look at these numbers. So for a 10 millicurie dose, the thyroid is going to pick up 10,000 or 11,000 rems. The testicular and ovarian dose, they're both quite small. We don't get too excited about 9 or 10 rems to the gonads. The whole body dose is typically around 15 or 16 rems. Again, those are all pretty small numbers. We're just not too excited about any of those. Now, I showed you this slide in the big chart, but I'll show it to you again. This is a decay scheme of I-131. It's not all of it. I only had room for about 14 of them, but they really are 19 different gammas. So number one, I think you had this question before, but this decay scheme shows you there are 14 different gammas and 6 different betas. And so true or false, 14/20ths of the tissue damage was caused by the gammas, 6/20ths by the betas. True or false?
False.
Sure, that's totally false for 2 reasons. I don't know if the reasons they're not here, but number one, you can't do 14/20ths and 6/20ths because betas and gammas don't confer an equal amount of energy. Betas confer all their energy. Gammas confer only a little bit. Also, what's critical here is what's the percent abundance of each of these gammas and each of these betas. Many of them are 0.2% or 1% or 2%. They might as well not even be there. They confer very little energy. Which one of those gammas is the one that we image with? I think I asked you that before. You recall that gamma 9 goes from 0.3644 down to 0. Here it is, 0.3644 down to 0. And that's the one we imaged with, through 0.364. I have a colleague who has taught for me. Yeah, he also is a PhD radiochemist, and he and I agree about everything except this. His department used to be at Michael Reese Hospital in Chicago, uses method number 1. And here's how that works. You can calculate the dose for treating Graves' disease. It's simple math. The problem is it's fraught with difficulty because there is so much uncertainty in the calculation. You can't look at a patient and say, I'm going to give you 60 microcuries per gram of thyroid, or I'm going to give you 80, or I'm going to give you 100. You don't know which number goes with a particular patient. No one knows. Secondly, how good are physicians at palpating the thyroid and estimating the mass? I can tell you in one word, terrible. No one's good at doing that. So there's a lot of uncertainty here, There's almost no uncertainty in a percent uptake, not because we did it, but a thyroid uptake test is a very reliable, very reproducible test. And so the only certainty you have here is this number. And so what happens here is because there's such a wide range of numbers here to choose from, we often end up underdosing the patient. Now, which is worse, underdosing the patient or overdosing the patient? Ready?
Overdosing.
Believe it or not, overdosing is not worse. Underdosing is much worse because what do you have to do? You have to give a second dose. Let's say, for example, 8 millicuries would have cured the patient, but your calculation said 6. You gave 6 and that failed. The second dose has got to be 50% larger, which is 9. 9 plus 6 is 15. If you had given 8 and cured him, you wouldn't have had to give the second dose. So you've ended up doubling his radiation dose because you underestimated the required dose. So underdosing is worse because in every case, you have to give an increased second dose. And so here's what we do. And we have an 85% cure rate on our first dose. If the patient is female, we start out with the number of 8. If the patient is male, we start out with 10. Men are considered to be more difficult to treat from the standpoint of the number of millicuries we have to give. It's not that their thyroids are larger. They may not even be. We don't even know why, but men require more millicuries than women. That's just a statistical finding. And secondly, we take a look at the uptake. We do look at that number and we say, gee, you know, here's a lady with 90% uptake. I'm gonna give her 8. Here's a guy with 39% uptake. I'm gonna give him 12. I mean, we make a medical judgment call based on these starting numbers and the thyroid uptake percent. And so this protocol adequately treats 85% of all patients. And on the 15% who are refractory to the treatment, where it fails, we're going to pick up almost all the remainder, rarely a third dose. So if the first dose fails, the second dose is how much larger than the first?
50%.
Good, 50%. Now, we're going to take a quiz in a few minutes, and I'm going to ask you this question, but the wording is going to be different, and the answer is going to be different. So watch the wording here. This says the second dose is how much larger than the first, and you'll see the other question coming up in not too long. Now, here's what we say to the hyperthyroid patient. You treated today with iodine. It's going to take 4 to 6 weeks for you to begin to feel better. You even to begin to notice any beneficial effects. Patients kind of groan because they really don't feel good, and they are treated, and they have to go off Synthroid and stay off Synthroid for a long time. So they really don't feel good. They want to be cured right away. But number one, this will not cure them right away. And we're glad. We want it to be weeks so that the dose rate is low and the effect on DNA is minimal. So 4 to 6 weeks, they begin to notice beneficial effects. What are those beneficial effects that they note? Number one, patients often have tremors in their hands. That goes away. They often have palpitations. Their pulse rate begins to slow down a little bit. By 12 weeks, that's about as good as it's going to get. After 12 weeks, there are things going on in the background, but the patient will never observe them. And so this says even at 6 months, very few observable changes at all. But in the background, the patient is slowly becoming hypothyroid, typically. I'm going to show you a graph here. It's just a graph I sketched. It's not the exact shape of the curve, but almost. And in this graph, you're going to see the rate of development of hypothyroidism after the first year. The first year is about 1/3 of all patients, let's say 33%. The next 10 years, it's going to be 3% per year. So out at a year 11, you started with 33% year one. In the next 10 years, another 30. So almost 2/3 of all patients are going to be hypothyroid by year 11. So here you can see the curve is not really this smooth, but just to give you an idea, we're starting at year one, and when we go out for 10 years, you'll note if we go back this direction, 33% are hypothyroid during that 10 years, plus another 33%. 2/3 of patients are hypothyroid 10 or 11 years down the road. Now, our physicians, our endocrinologists send us these patients, and they say to us, make the patient hypothyroid. We don't want a euthyroid patient. We want to put the patient on Synthroid for the rest of his or her life. And that's the goal, to make the patient hypothyroid. Now, what are the ways, we're going to talk about some radiation safety stuff now related to iodine in patients. Number one, in the good old days when we gave iodine in the form of a solution, we had this device here. It looks like straw-like tip. It's a long tube. Here is what it looks like. That's a photograph of it right there. And so we put this long needle, it looks like a spinal needle, into the vial containing the iodine. There are only 1 or 2 milliliters in there. The patient sucks on this end, pulls up the iodine until there's none left, and then we inject tap water into this vial while the patient continues sucking on this end to rinse the vial. We do that twice. We rinse it twice, and we are able to transfer over 99% of the iodine into the patient doing that. Having said all that, almost no one does that anymore, and they're simply using capsules. That makes it very easy. Now, the following precautions are going to be related to low-dose iodine therapy. Number one, we want everyone, both the dose administrator and the family at home, to keep the simple principles of radiation safety in mind. You might know the TDS concept: minimize your time, maximize your distance, and S is shielding. Put as much shielding as you can in between. That's very hard to do. So we want to minimize time in close contact with the patient who's going to be very hot and irradiating like a point source in every direction. Really can't get away from it. The inverse square law is going to be your best friend. As you back away, the intensity of that source goes down very, very rapidly. It's a square relationship. Also, we're going to make a big deal over good hygiene. The patient has to keep the toilet clean, keep the sink clean, keep the tub clean, keep their hands clean. One of the issues is that iodine is secreted in perspiration. So the outside part of your body becomes contaminated with iodine. You can't see it. It's invisible, but we're constantly perspiring. It's simply drying on our skin. And so your hands will always have some radioactivity. So if you're going to touch anything that another person's going to use, you should be wearing disposable gloves. We want to keep our distance. Everyone involved with the patient's care must wear a film badge. The dose administrator who gives that capsule has to wear gloves. And if you're a participant in therapy, participant is defined as you stood in the room watching the procedure. You're a participant. Everybody should have his or her thyroid counted 24 hours post-dose. Male patients, excuse me. For male patients, we tell them that they must sit down when they're urinating because otherwise they will contaminate the floor. My children were very young. They used to sing a song that started out, "Do you sprinkle when you tinkle?" And unfortunately, we guys do that. We just can't help it. And so male patients should be seated when they're urinating, and patients should not be sharing anything with anyone for at least 7 to 10 days. There are some other things, no intimacy at all, certainly the first 3 days for low dose and longer for a high dose. Very important to keep your distance from children and pregnant women. Totally contraindicated during pregnancy. What probably would happen is the iodine would cross the placental barrier, get into the fetus's thyroid, and create what's called fetal hypothyroidism syndrome, which develops cretinism and seriously decreased intelligence. So totally contraindicated during pregnancy. What about nursing? Nursing mom has to have an iodine therapy. She has to stop nursing for that child. Every other isotope has a period of time associated with it. For example, for technetium, nursing mom has to stop for 1 day. For other isotopes, it's a few days. Iodine 131, that's it for that child. You cannot nurse. Also, if the patient's planning to become pregnant, then we recommend waiting. Some people recommend 1 year, some 6 months, but everybody recommends waiting to get pregnant. What if you have a situation where let's say it's a single mom who has a baby, and she's very radioactive? At all possible, she should try to find someone else to help her to take care of that baby. She should not be doing it unless she just has no other alternative. Again, good hygiene, keeping your hands clean. Keeping your hands clean, washing the toilet and so on. Sink, the tub. No one should even be able to accidentally use anything that belongs to like a toothbrush or a towel or anything like that. Also, we want the patient to be very well hydrated. We want them to urinate as often as possible because we know that iodine is going to be secreted in the urine, and that's how we're going to get rid of the excess iodine. Also, for eating utensils, so plates, plasticware, napkins, everything should be disposable. You should put it in, put it in a separate bag for monitoring and then disposal. Now, what if it's a high dose patient? Then in addition to everything we just covered, there are a few more things we need to take a look at. Of course, everybody has to keep their distance. If the patient is hospitalized, the patient has to be in a private room and cannot share a room with anyone, not even another therapy patient. Everybody involving the patient has to wear a film badge. And the patient has to be wearing disposable gloves if he's going to handle anything that the next patient might use. The telephone, the bed controls, the radio controls, the TV controls, anything like that. The patient has to wear gloves. So here, he's thinking, gee, she's a cute girl, but she is, in every sense of the word, a hot chick here because she's loaded up with iodine. So he's standing a minimum 6 feet away, and he'd be better if he stood farther away. She has to be in a private room. She can't share the room. There's a film badge that we all have to be wearing. She is demonstrating wearing of gloves while she's talking on the telephone. housekeeping. We don't even let housekeeping in the room until the RSO surveyed the room and released it for patient use. No visitors for 24 hours. Now, that is our policy. The NRC actually permits a 30-minute visit in the first day. Everybody I know thinks that's one of the stupidest ideas there is. If the patient is well enough to have this procedure, is well enough to pick up the phone or his computer, have a Zoom conference, do something to connect with his family. Nobody needs a visitor the first day when you've got 150 millicuries on board. No bed baths. All you succeed in doing is taking a wet washcloth and wiping it on somebody's arm and blowing iodine all over the place. No bed baths. They took a shower before they got into the hospital. They're going to be out in probably 2 days. They're not running laps, so they're going to be fine without a shower. We don't want the patient walking around. The more the patient walks around, the more the room is going to be contaminated. So here, he's telling her no visitors. And here, no bed baths. And here, again, we want her staying in bed unless instructed otherwise. We tape Chuck's pads. I think you all know what they are. We tape Chuck's pads, absorbent pads, from the toilet to the bed. That way, if a patient, in particular a male patient, takes that walk from the toilet to the bed, and if he drips urine, it will fall on that Chuck's pad, which we can ball up and throw away. If it falls on the floor, we have a lot worse situation than you might think, because the iodine in the urine iodinates the polymer in the floor. It's very, very hard to decontaminate. I've heard stories about RSOs having to take up floor tiles because they couldn't be decontaminated. Everything that is for food service has to be disposable. For diagnostic blood samples, we want a nuclear medicine person to take it. That tube falls on the floor, it breaks. We know how to clean up spills. Other people might not know, probably do not know, might not even know it's radioactive. So here are the Chuck's pads. We tape them from the toilet all the way to the bed. Now, here is a medical catastrophe. You don't expect the patient to die. In fact, this almost never, ever has happened. Just a very few times reported in the literature. If the patient is having this procedure, he's reasonably healthy at that moment in time. Now, let's think about the following. The patient has no thyroid. He's been thyroidectomized. He has no thyroid. He has good kidney function. He's being well hydrated. And because he's urinating a lot, getting the background iodine out of the way, he has a biological half-life of that iodine of, let's say, 1 day. Now, when he dies, let's say if he dies, what happens to the biological half-life of the iodine now? What is it? Remember, it was 1 day while he was alive, but now he's dead. What is his T biological? Is that iodine ever going to clear his body?
No.
No.
No. Therefore, how long is it? So his biological half-life is going to be forever. It's going to be infinitely long. And if you recall from, I think, the first or second lecture we had, if the T biological is infinitely long, then the T effective equals T physical, so equals 8 days. That means he is now an inanimate object with a physical half-life of 8 days because there's no way to clear it out. And that's because his T biological went from 1 day to infinitely long. And of course, you have to notify the attending physician immediately. No one expected that he would die. After the patient leaves the room, and we're talking about a normal patient who's still alive, RSO has to survey the room, and everybody should have his or her thyroid counted 24 to 72 hours post-dose. So here, he's calling the attending physician to notify him. Here, the RSO is surveying the bed and the floor to make sure that there's no contamination. Now, my model is now pretending like she's the dose administrator, This is a Geiger counter, a totally inappropriate device for checking the thyroid for iodine 131. But I'm just showing you the geometry where this is simply held against the dose administrator's thyroid. In fact, the probe that we use is about 4 inches in diameter and very heavy, and it's calibrated for I-131. Signage. Which of these two signs do you think is more important to put on the door of the room where you do therapy? Caution radiation area or caution airborne radiation area? Which one is more important?
The left?
Which one?
The radiation area?
Good. Many people get that wrong, but the caution radiation area is mandatory. The airborne radiation area, you can put it there if you want to, but the reason it's less important than it was 25 years ago is manufacturers now put a chemical called sodium thiosulfate in the iodide. That prevents it from becoming volatile and converting to iodine, which is volatile. And so because of that chemical modification, there is never any airborne iodine. So if we don't put that sign up at all, it doesn't matter. So the caution radiation area, that's the important sign. If you had your notebooks in front of you, I would tell you to put a star by this slide. Common exam question. What is the NRC release criterion for a hospitalized patient? This is only for a hospitalized patient. And here's what it is. If the reading drops below 7 MR per hour at 1 meter from the patient's chest, that is basically equivalent to 33 millicuries of iodine, but this is really the criterion. The reading has to be less than 7 MR per hour at 1 meter from the chest, then you could let the patient go home. Now, some agreement states, this is not a board question, but some agreements states say, I don't think that's strict enough. I think we should keep the patient until the reading goes down to 5 MR per hour. Okay, well, that's not something to know for an exam, but you should know that you have the right to be more restrictive if you choose to. Okay, any questions about iodine therapy? Anyone? Okay, next let's talk about palliation of pain from bony metastases. Now, one of the most important statements I can make to you is that we cannot cure the patient. This is strictly a palliative move. That's a move that is going to improve the quality of life of the patient by decreasing the level of pain that that patient is suffering from. So there are several drugs today, strontium chloride, and samarium bone agent, which is almost never used anymore. What's not listed on the slide, of course, is radium-223 chloride. That's probably the agent of choice today. Now, the eligibility criteria, and I'm showing you these numbers for strontium, but it's pretty much the same for all of them. If the white cell count is less than 2,400, now what is normal? Normal is 4,000 to about 10,000. So this is about 60% of normal. If it's less than 2,400, we think twice about doing this because these drugs often knock these counts down, and in some unusual cases, they never come back to normal. And so if your white cell count is too low, you're prone to infection. If your platelet count is too low, you're prone to bleeding events, and we don't want that to happen. So there are times when we have to say, gee, I'm sorry, we can't do this. The cell counts are too low. Also, if the patient is either pregnant or nursing, totally contraindicated. This is a therapeutic isotope, totally inappropriate for a pregnant or nursing person. If the patient is moribund, that means the patient is about to die. The rule of thumb is 90 days. If you think the patient has less than 90 days to live, you should not be doing this procedure. You should be using morphine and other pain relievers. And even the manufacturer says this. The patient is not going to live 90 days, don't treat it. And also, you are permitted to retreat. Even if you haven't had a good first effect from the first dose, you're permitted to retreat if you choose to, but no sooner than 90 days. Also, here's something I think interesting scientifically. Osteosarcoma is a primary bone tumor. And believe it or not, this is worthless for treating osteosarcoma. Nobody knows why, but for some reason, these drugs wash out of osteosarcoma pretty quickly. And so it's not very effective for that. Now, this is a 20-year-old slide just showing you some epidemiological numbers for males and females. You can see that the numbers of cancers that are metastatic to bone are in the hundreds of thousands on each side here. So we're looking at, 400, 500,000 patients a year who are having some kind of cancer metastatic to bone and causing bone pain. Now, let's take a look at the physical properties of both strontium and samarium. More important, really, is the strontium. Strontium has a 50-day half-life. I like to think that this is a gift that keeps on giving. It has a very long biological half-life, and a very long physical half-life, which means it's going to have a long T effect. It's going to dose those metastases over and over for a long time. So it's going to last a lot longer than anything else. On the other hand, samarium has a half-life a little under 2 days. So we would expect it to dump all of its energy rapidly, and we would expect the onset of relief to be much quicker, well, let's say a week earlier with samarium. But we prefer the much longer lasting effect here. So we don't want the patient to suffer that extra week, but we just say, if you have to increase your morphine a little bit, why don't you do that for the first week or even 2? And then once you start getting pain relief, you might be able to go off of the morphine. These are both beta emitters. This is a higher energy, roughly 1.5 million electron volts. This is a little over half of that. This range in tissue is not the average distance traveled, but the maximum. Strontium betas go a maximum of 8 millimeters, an average of about 3. This is 5 millimeters, an average of about 1.5 or 2 millimeters. Now, there are many people walking around today, or maybe not walking, because of bone pain. And why is that? There's longer survival today for many kinds of cancers. We do have better pain control medication and also very aggressive radiation therapy up to the point where we can't do it anymore. That's a very good pain reliever. Now, let's look at epidemiology. Prostate cancer. Half of all people with prostate cancer have bony metastases at the time of diagnosis. And even for breast cancer, 1/7 of stage 3 and half of stage 4 breast cancer patients also have bony metastases. So there's a lot of people walking around with painful bone disease. Now, you should not think that prostate cancer and breast cancer are the only two where it's permissible to use these drugs. That's not the case. Any primary is totally acceptable, but you must have a bone scan positive for metastases, or it is malpractice to do any of these therapies. You must have that positive bone scan. Now, the palliation of pain. What are some of the effects of bone pain? You can look at the list here. The bottom line is this one. It just simply ruins the quality of people's lives. They can't work. It disrupts family events that are going on. People become depressed and so on. So there are lots of approaches, and here they are. There are non-steroidal drugs, non-steroidal anti-inflammatory, Advil, Aleve, aspirin, ibuprofen, those kinds of things. There are bisphosphonates, that's a different kind of chemical. There's, of course, classical chemotherapy. Nobody would do chemotherapy to relieve pain, but it does help a little bit in the beginning. Hormonal therapy, many people have hormonal therapy, both male and female. External beam therapy, very effective, but very expensive, and a limited number of times you can use it before you've reached that limit. Narcotics, what we're going to concentrate on, of course, is the very last one, therapy. So I'm going to kind of fly through the next few. Non-steroidal drugs, aspirin, Tylenol, Advil, they don't work well. Maybe in the beginning when the pain is mild, they'll help, but that's for a short period of time. And so that's not very helpful. Chemotherapy, again, we would not do this just to relieve pain, but in the early stages of disease, it sometimes does take the pressure off the bone and relieve the pain. Hormonal therapy, it's most effective if you start it before the pain ever shows up, but it only works in hormonally dependent tumors. Certain forms of breast cancer are estrogen dependent. Certain forms of prostate cancer are also testosterone or hormonally dependent. I have a brother-in-law who's had prostate cancer for almost 15 years, and he was on a hormone blocker, which helped a great deal to control the growth of his disease, but it caused all kinds of other issues that men need testosterone to perform normally, just in general, life in general. And so it caused a lot of problems, decreases libido, causes impotency. And one of the things that they might like to do is, instead of giving these hormones, in some men, they suggest castration. And believe it or not, many men will say, I'd rather die than have to undergo castration. I've heard men say that. They'd rather die. These hormonal therapies have some undesirable side effects, and it's really just not very effective overall. External beam therapy, very effective for localized disease. You might say, oh, my leg is hurting me. They'll irradiate it a few times and pain goes away. And then what that often does is it unmasks other sites of pain, where the leg hurts so bad you didn't feel your arm pain, but now your arm hurts. So they can retreat that. They can do what's called hemi-body. I don't know if it says it on here yet. Hemi-body radiation, that can be very effective also. But there's a limitation of how many times you can do this, because too much bone marrow radiation dose from therapy can create lots and lots of really bad problems. So it's very effective, but limited number of therapies, and it's very expensive to do it. Narcotics, bottom line here, they're great pain relievers, but they ultimately decrease quality of life, because people very often become drug dependent. They have loss of appetite. These drugs cause constipation in almost everybody. People become depressed, confused, disoriented. They hallucinate. So I like to say that morphine is a wonderful, terrible drug. That's just the best way to put it. So what we're going to talk about is radionuclide therapy with radiopharmaceuticals. And the history started back around 1945 with P32 sodium phosphate, 1988, strontium, 96, samarium, and 2000, and I think 18 was Xofigo, the radium chloride. So P32, a very long history, good response rate, 75% response rate, but this drug depressed bone marrow more than anything else, and it ended up not being used that often. For many, many years now, probably 30 years, we have used the strontium. What are the indications? Now, listen carefully to the wording here. You must have a documented malignancy with metastases. There must be a positive bone scan. Also, significant use of analgesics. If the patient is coasting along and say, hey, I'm taking Advil and I feel great, you should not be giving him strontium. But if he's on morphine and not doing great, then that's the time to do it. Also, we mentioned this already, life expectancy, more than 3 months. We don't care if there are multiple sites of disease, because this drug goes everywhere in the body, treats all parts. It's perfectly okay to do it in combination with therapy, radiation therapy, and also other kinds of therapy, but you may not want to do it on the same day. Somebody had radiation therapy or chemotherapy today. I wouldn't give them strontium today. I'd wait perhaps a week. So again, we tell the patient, we're sorry, palliative but not curative. Strontium is a calcium analog. Remember, it's right beneath calcium in the periodic table. And I've seen a strontium 85M bone scan, looks identical to an MDP bone scan, you cannot tell them apart. So we can either trace phosphate with MDP or calcium with strontium. Overall response rate from strontium is 80%. Now, keep in mind what that means. 20% of all people are not going to respond at all, or maybe even get worse. Why does this work as well as it does? The ratio of uptake of lesion to bone is 5-to-1. That's good. We'd rather irradiate the lesion than the bone. And lesion to bone marrow is 10-to-1. That's even better because that's minimizing bone marrow dose. It's still very high, but minimized. Also, this is good. Strontium is retained in the metastases longer than the bone. So not only does it go there preferentially, but it stays there longer. Nobody has ever reported an adverse reaction with strontium. That's pretty amazing. Now, a third to a half of all patients have measurable decreases in white cells and platelets, not red cells. So we have to do a CBC before we ever start to know what their counts are. And we see patterns in two different kinds of patients. One is we might see a totally level of white cell and platelet counts over a period of 12 weeks. Here's what we typically see. We see that as the weeks go by, it goes down to weeks 1, 2, 3, 4, 5, 6. That would be the lowest it could be. And by 12 weeks, it comes back to normal. Sometimes it never comes back. Most patients, it does. Also, there's something called a flare phenomenon. We say to the patient, your pain may flare up after getting this injection. If so, you may need to take a little bit of morphine, but that is a good sign that this procedure is going to work successfully. Typical dose for millicuries, it's pretty hard to overdose a patient because the vial only contains about 5.5. So even a full vial would be almost impossible to overdose anybody. The bone marrow dose is pretty high, 320 rads or rems. The bladder dose is very small because strontium is not even excreted in the urine. And the whole body dose is moderate. I'd like to talk about this slide. This 80% response rate is divided into 3 groups. The moderate response, that is, the patient was on morphine and now is getting by with codeine. It's still a narcotic, but not as hard a narcotic as morphine. There's a marked response, really good response, where the patient went from morphine to a non-steroidal drug like aspirin, or Advil, or Tylenol, or something like that. That's a wonderful response. And then this one, I've seen several of these, a dramatic response. We had a gentleman who came down from Michigan. We treated him. He had a PSA level of 350. Put that in perspective, normal is 0 to 4. So his PSA level is 100 or 200 times normal. He had prostate cancer everywhere, a super scan. We gave him 1 5 millicurie dose of strontium. He came back in 6 weeks. His wife was pushing him in the wheelchair. When I injected him 6 weeks earlier, he couldn't even stand up. And he says to me, is your boss here? I'd like to talk to him. And I'm thinking, uh-oh, it's not good when they want to talk to the boss. And I said, I'll go get him, introduced my boss. And the patient pointed at me and he says, that guy injected me 6 weeks ago and I want to show you something. He literally jumped up out of the wheelchair, grabbed his wife, and they went dancing down the halls in our nuclear medicine department. Here's a guy that couldn't even stand up 6 weeks earlier. And he had dramatic pain relief for a full year. By the time he came back for a second dose, his PSA level had gone from 350 up to over 900. And he, of course, succumbed to the disease in the following year, but we gave him quality of life for way over a year. It was one of those dramatic responses. It reminds me of the faith healers. You know, they put their hands on your head and say, be healed, my son. And next thing you know, people are saying, I'm throwing my wheelchair away. Well, this is not quite that fast, but in effect, that's what happened. Not much new to say about samarium, except that it's a phosphate analog is bound to a phosphate bone agent. It happens to have a gamma we could use. And while it has a more rapid onset of relief than strontium, strontium's duration is much longer. Again, 80% pain relief, 20% of prostate cancer patients become totally pain-free. That's a remarkable thing. And while the range of relief is 4 to 12 months, it's really usually more like 2 to 5 months. And it's longer than that with strontium. Now, Xofigo. Remember, with these others, we were giving millicuries, 4 millicuries for strontium and a lot more for the bone agent, the label bone agent. But this is different. This is an alpha emitter, radium chloride. And so we're giving 1.5 microcuries per kilogram body weight. Let's say a guy weighs 70 kilograms, 155 pounds. He's only going to get 1.5. That's about 100 microcuries, total dose, 100 microcuries. But remember, this is a very powerful alpha emitter. It's going right to the bone marrow, to bone and to bone lesions, and it's dumping all of its energy in those lesions. And so we're giving roughly 100 microcuries total dose every 4 weeks or 6 cycles. So we would never think 100 microcuries of anything is going to have any effect on the body, but this truly does. It has become the agent of choice. And it's for men who have castration-resistant or hormone-resistant prostate cancer, symptomatic bone disease, no metastases anywhere else in the body. And we're just counting on the alpha particles to cause double-stranded DNA breaks that are lethal to the prostate cancer cells. That's pretty much how it works. It's given intravenously. And we, of course, have to inspect it to make sure that it didn't turn a funny color, it has no particles. And we have to flush the line to make sure the patient got the whole dose. I'm not going to review these eligibility criteria. They're in your lecture notes if you want to take a look at them. Basically, you have to look at the complete blood count, just make sure that that everything is in good condition before you proceed. And this is a nice graph because this first one up here shows you the block of time, this yellow block of time, where you have a short half-life therapeutic. And look what something like strontium would do. This yellow area is a much larger block of time than this really short one. And this is why the samarium doesn't last nearly as long as the strontium does. I'm skipping P32 because they're not going to ask you about it. Zebulin lymphoma therapy. We have yttrium-90 bound to CD20 receptor sites that are on B-cell lymphoma. And so the yttrium-90 is a labeled antibody to certain forms of non-Hodgkin's lymphoma. We are limited to 32 millicuries, no matter how big the patient is, because yttrium can break off of the antibody. And unfortunately, where it goes is the bone marrow, and that's not good. And so there is a limit. Microspheres, they're either glass or polystyrene resin microspheres, and they require an MAA study where we inject the MAA through the catheter and make sure that it lodges in the liver before we inject the microspheres in through the same catheter into the liver. This is just a quick check to make sure that the position of the catheter is in the right place. Also, we're doing very often lobar injections. We don't do the whole liver. We might do the left lobe and then come back 2 weeks later and do the right lobe. Finally, Lutathera is a therapeutic that is for certain, what they call GEP-NETs. They are a certain form of neuroendocrine tumor. I really don't know too much about them, but they are located in different locations in the GI tract. Its molecule is called dotatate. It's a really big molecule labeled with lutetium-177. It actually decays to a stable product. And the half-life of lutetium is about 6.6 days. It's a beta emitter, about a half an MeV. And look at this, it's got two perfect gammas, 208 keV and 113. They're both within 100 to 250. So if we wanted to image, we could. And in fact, those images are beautiful. They look really good. We're giving 200 millicuries every 8 weeks for 4 doses. This is a very expensive drug also. And it's cleared through the kidneys, but not the liver. And very finally, I want to mention some radiation safety aspects. We really have covered most of them. And just a couple of things I want to make sure that you understand the difference between exposure and internal dose. Exposure has to do with what is the source? Is it internal to your body or external to your body? For example, radiation dose is always internal. You could get an internal dose, but where did it come from? Is it internal to your body? Did you breathe in iodine? Did it get in your thyroid? Or is it external? You're standing 3 feet from a radioactive patient. You're getting an internal dose from an external source. So this says that the external exposure will be only from X-rays or gamma rays. And an internal exposure could be from anything, X, gamma, beta, alpha, anything. But external can only come from something penetrating like X or gamma rays. And very finally, bioassay. This is the assessment of radioactivity level. That could be either on the surface of the body or internal to the body. Here are some examples. When you as a technologist will be monitoring your hands every day, that's a form of bioassay. You're checking to see if your hands are hot. Collecting a urine specimen and counting it, that's a bioassay. Someone counts your thyroid to see if you're contaminated. Doing a whole body scan to see if you accumulated some iodine or some other isotope. Those are all bioassays. And I think I mentioned earlier, but I'll repeat it, the TDS concept, time and distance and shielding. It's not too hard to minimize your time around the radioactive source. It's not too hard to distance yourself from the source. What's really hard is shielding yourself from the source. Like when you give a patient radioactivity, you can't put him in a lead box. So how do you shield him? It's pretty hard. So you want to minimize your time so that shielding is not much of an effect. Okay, let's go ahead and take this test on radionuclide therapy. I don't think we can finish it in 10 minutes, and we may run over a little bit today, but that'll be the very best stopping point. So let's go ahead and proceed. Okay, you can feel free to unmute yourself if you have a good answer for any of the questions. It says, which one of the statements is false? Let's just go down the list, say true or false for each one. In a beta gamma emitter like I-131, the ratio of tissue damage is approximately 90% from the betas, 10% from the gammas. True or false?
True.
True.
True. Target to non-target ratio is more critical therapeutically than diagnostic.
True. True.
True. You could kill the patient therapeutically. You can never harm the patient diagnostic. The T effective, the ideal T effective of a therapeutic is 1.5 times the procedural length.
False.
False.
That's false. That would only be true for a diagnostic. For a therapeutic, the ideal T effective is simply moderately long T effective, like days. Particles are preferred to photons for therapy.
True.
True. We use beta particles. We use alpha particles. Very good. There's a lengthy explanation for that. Which one of the following isotopes has no current applications in therapeutic nuclear medicine? This is kind of I didn't mean it to be a trick question, but I've had a lot of people tell me they think it is. What do you think? Let's go down the list. We use yttrium-90?
Yes.
Yes. Iodine? Yes. P32? We could. We don't anymore, but we could. Strontium-85? No. Samarium? Yes. This is the correct answer, D, because the one that we use is strontium-89 and not 85. Okay, which one of these is true? Let's go down the list. Both strontium and iodine decay by beta plus emission.
False.
False. Both decay by beta minus.
True.
True.
True. Okay, so the rest are all going to be false, but let's take a look at it. Both of these emit gamma rays. That's false. Strontium does not. The radiation risk to the patient would be the same for both of these. I-131 would be way more. Both require hospitalization. Strontium would never require hospitalization, ever. Of the 4 types of thyroid cancer, which 2 are treatable and which 2 are not? A, B, C, or D?
D.
E.
D, follicular and papillary are treatable. The other 2 are not. For a hyperthyroid patient with a 50% uptake and a 10 millicurie dose of iodine, what will be the thyroid radiation dose? I showed you that little chart from the Mallinckrodt package insert.
Is it
You ready?
D?
D, very good. 10,000 or 11,000 rads or REMs to the patient. Okay. Now, I told you in an earlier slide that it will take X weeks to begin the beneficial effects from iodine and Y weeks to reach the maximum beneficial effect.
C.
C, takes 4 to 6 weeks to begin to feel better, 12 weeks, that's the maximum that the patient would observe. Right. What's the long-term side effect of a successful therapy?
B.
That would be B, hypothyroidism. It's actually a desirable effect. We want the patient to be hypothyroid. Okay. The release criterion is if you've chosen to hospitalize a patient.
C.
E.
C, right? It's 7 MR per hour. And don't forget, it's at 1 meter. It's not at the patient's body surface, 1 meter. It's not 5. You could do 5 if you want. That's not the law. The law is 7. Which one of the following is false? Let's go down the list. Use of strontium is palliative. Sorry. Use of strontium is palliative, but not curative. True or false?
True.
True. Use of strontium has a response rate of 80%.
True.
True. Strontium may cause pain to flare up.
True.
True. Use of 4 millicuries of strontium confers a radiation dose of 25 REMs. And that is totally false. It's 10 times that much. It's 250 REMs. This is P. Vera. I'm going to skip that. Which of the following therapies involves use of an unsealed source in the body?
C.
C. Radiopharmaceuticals are unsealed. We put them in the body and they go where they want to. We have no control over where they go. So brachytherapy is a sealed source. Teletherapy is a sealed source. Neutron therapy is an outside of the body sealed source. None of those is in the body except choice C. Number 12, which of the following therapeutics is the most risky for the dose administrator?
A.
A.
Sorry. That would be A. The other 3 are pure betas with no gammas. Iodine has 19 gammas, so A. Which one of the following is not required for a high dose therapy for thyroid cancer? A, room has to be surveyed by the RSO. Is that required or not?
Required.
Required.
Good. Everybody has to be wearing a film badge.
Yes.
Required.
Required. Sorry. Everyone has to give up a urine specimen.
Not required.
Not required. Patient has to be in a private room.
Yes.
Required. Typical prescribed doses for treating Graves' disease and hot nodules respectively are
A.
A, very good. Graves is about 8 or 10. Hot nodules is 25 to 30, but in nominal numbers, 8 and 25. Okay, now I told you I was giving you this question. Now watch the wording because this is not going to be a 50% increase. If the first dose fails, the second dose should be equal to,
C.
good, C, 150% of the first dose. I got a report from a radiology residency that was how the question was phrased on an exam. So I put it in here. 16. All right, we had this ready. Gamma 9 is 0.3644. And we've had this question also. Since the decay scheme shows 14 gammas and 6 betas, the ratio of tissue damage caused by betas to gammas is none of those. It's 90%. Which one of the following is true? Let's go down the list. Women are more likely to be hyper and are more difficult to treat than men.
False.
False.
False. B, women are more likely to develop hyperthyroidism and less difficult.
True.
True. Let's see what about the other two. Less likely to develop hyper, that's false. So you know that the correct answer is you're more likely but less difficult. Number 19, what are the approved indications by the FDA for palliating bone pain? A, the patient presents with bone pain and requests a strontium therapy. Approved or not?
Not.
No.
Not. Patient can't say, give me strontium. I read about it on the internet. Patient presents with bone pain from breast or prostate, but no other primary.
Not.
No.
Not. Patient has osteosarcoma, but no other primary.
No.
Not. And so D is the correct answer. The patient has bone pain caused by bone metastases from any primary malignancy. Number 20, which one of these is false? Let's go down the list. The biological distribution of strontium 89 is essentially identical to that of MDP.
False.
That
true.
that is true. I remember I told you that a strontium bone scan and an MDP bone scan are identical. So the distribution would be the same. So that is true. Strontium is a calcium analog.
True.
That is true. Right beneath in the periodic table. Therapy with strontium is both palliative and curative.
False.
False. One reason that strontium therapy is effective while minimizing bone marrow dose is that it is retained in metastases longer than in normal bone tissue. That is true.
Sure.
So the only false one is choice C. We're almost done, just a few more. Typical injected dose of strontium is
B.
B, 4 millicuries. B32 phosphate. Oh, that's all happens to be 4 also. We're going to skip that. We're going to skip that. And it is exactly 12 o'clock and we are perfectly finished with this. And next week, we're going to cover multiple topics. We're going to cover internal radiation dosimetry, personnel monitoring devices, and some units of radiation. And I'll take a look and see what other topics there are. And then what I would like for you to do during the week is take a look at any old exams that you've got. If you have any questions that you would like for me to discuss with you online next week, you can either email them to me or give them to your program director to email them to me, and we can discuss them next week. And also, I want, depending on how far we get next week, I want to discuss all the problems on the 2 math tests that we've had. A lot of people have been taking the math tests, and some people are excelling at it, and some people are not. And some of the math problems are a little bit difficult. So we may discuss some math problems next week, but it will be beneficial to both you and me if you can find any questions that you have about anything we've covered, anything from old exams or recalls or books, any questions that you have, you would like me to help you solve related to my region of expertise. I'll be glad for you to send them to me. Your instructor has my email address, and also I do believe the last slide, let me back up a little. Let me see what's here. Yeah, so you can reach me at this email address, nucmedconsultants@comcast.net. If you have anything you would like If you have anything that you would like to send to me, and I'll be glad to tackle those problems next week. Any questions today from anyone about anything that we have covered? Anyone? Okay, if there are no questions, then thank you again for your attention, and I will see you next Thursday at 9 o'clock. And until then, hope you have a great week. Thank you.
Thank you.
you.
See you soon. Bye-bye.